It is a huge honor today for me to be in Medan. Did I pronounce it right?
That's
Medan,
right, Medan.
Indonesia.
Oh, Medan, yeah. The Malay pronunciation would be Medan.
Malaysia would be Medan.
Yeah.
With one of the biggest rock stars in aesthetic dentistry in Asia, Dr. Ronnie. How are you doing, Ronnie? Now, your name, Dr. Ronnie Yap Yeroon. Ronnie is just, you go by Dr. Ronnie because that's a name, a British
It
nickname.
started as a nickname because my first name is Yeroon, but my father's friend, when I was young, he had a hard time pronouncing it, and he was from the UK, so he gave me a nickname, Ronnie, and it sort of stuck from that day onwards. Yeah.
You know, I had the same experience when I was in Shenzhen. I was talking to a friend of mine. I said, "So Godfrey," I said, "is that your first name or last name? What's the rest of your name?"
My family name would be Yap.
Yeah.
Y-A-P, and so my first name is Ronnie, so it's just easier, just call me Ronnie. And
that's what Godfrey said. He said, look, he says, when we were in Hong Kong in a British school, he goes, we all learned by the first grade that no non-Chinese, no Americans or British were ever going to be able to pronounce their names. So he says we stood in line, and there was a basket of names, and I filled out mine, and my British name given at school first grade was Godfrey.
Okay.
And I said, well, what's your real name? And he told me his real name, and I
can't remember. Yeah.
I couldn't repeat it for 1 second. But you are the president-elect of the Asian Academy of Aesthetic Dentistry. That's a huge accomplishment. You were the first Invisalign dedicated clinic in Singapore, which I find so amazing because of all the specialties out there. The Orthodontic Society is the closed society. I mean, no non-orthodontists are allowed.
Well, in Singapore, we are allowed, as a general practitioner, we could be associate members of the Orthodontic Society, just that we have no voting rights. Yeah.
Okay, so you get to go to the meeting, but you can't vote.
Yeah, that's right.
And well, in America, you're not even allowed to go to the meeting.
Okay.
So I think that's pretty impressive that Invisalign, they pick you, you don't pick them. And you were the first Invisalign dedicated clinic in Singapore. You've done thousands of Invisalign cases. And then another thing that I maybe we should start talking about is this new thing. We're here in Indonesia, and you're giving a hands-on course with bulk fill posterior composites.
That's right.
Can we start there?
Because, I think in Asia, as you know, the countries are all quite different. And Singapore, because of good governance over the years, is sort of looked upon as a little bit more progressive or more advanced compared to the rest of Southeast Asia. But in the last 10 years, I think the rest of Southeast Asia has caught up very, very quickly. In terms of dentistry, I think partly due to the internet as well, so the level of dentistry has changed a fair bit. So what happened was about 10 years ago, I went, a bit more than that, 12 years ago, I went for some CDE in America, which was not that, a bit unheard of then. Yeah, and that was where I learned a bit about, amalgam, going amalgam free and doing posterior composites, and attended a hands-on course by Ron Jackson. And so when I came back, I decided to...
was that a hands-on course at LVI?
Yeah, that's right.
Because he was an instructor at LVI for a long time.
And he just recently retired, I think last year, from LVI. Yeah. So basically, the lectures from Bill Dickerson really changed my life when I first heard from him. And because prior to that, we don't get that much exposure in Asia to the overseas speakers then. Yeah, so I came back and pretty much reorganized my practice and started to be sort of the dentist I wanted to be, because many times in Asia you are learned to sort of conform, to do things as they are. Yeah, but I think traveling sort of opened our eyes to see what's actually possible with dentistry. And since then, it's just been continuously learning, sharing, and trying to improve each time. Yeah.
When you are president-elect of the Asian Academy of Aesthetic Dentistry, does Asian aesthetic dentistry, does their culture, is it any different than, say, Europe or any different than America? I hear things from dentists around the world that, like some countries in the Middle East, want that really white Hollywood smile, and other countries in the Middle East are like, that is too white. What is it like in Asia?
We are somewhat between the US and the UK or Europe. I think in the European aesthetics, they tend to like natural looking layered ceramics, a bit of staining and transparency, translucency. Because I think in America in the past, it used to be really white, the Hollywood smile. So here in Asia, I think the influence from both Europe and America is pretty strong. Yeah, so pretty much when the patients come in, we have both groups. There are some who really want whiter than white, B1 and above. And then there's those that do not want, just want a nice, natural-looking smile, and they don't want their friends to know that they have veneers. So it can be quite a challenge. We really have to have a wide repertoire of techniques, and we need to also have access to laboratories that support the type of dentistry that the patient wants.
And put this in perspective for you kids out there under 30, when I got out of school, they had the bleaching shades. Mm-hmm. But then when they came out with tooth whitening, they had to go back to the drawing board.
Mm-hmm. That's right.
And make several shades whiter than anything.
Yeah.
Than anything available, and they called them the bleaching shades.
That's right.
So
BL1, BL2, and 3 and 4. Yeah.
Yeah. So that's not too white in.
Depends. I mean, color is really the perception, of the patient. So depending on what they do, their professional life. So there are some of them who are quite like, for example, we are the dentists for the Miss Universe Singapore. Our practice has been the official dentist for the last 6 years. So typically for the winners, because they compete internationally, we have to give, if they do veneers, you have to go for at least a BL3, if not a BL2. Yeah.
But don't you think the Miss Universe pageant is rigged because the winners are always from planet Earth?
I'm not sure about that, yeah.
Have you noticed no one from any other planets or any other galaxies ever win? So I think it's a rigged competition when the winners are always from Earth. Let's go back to bulk fill.
That's right.
I think that most dentists will tell you that it's just easier to prepare a posterior MOD for a crown. Mm-hmm. A lot of them think it's easier to do a CEREC inlay. Mm-hmm. A lot of dentists just don't like doing an MOD.
That's right.
It takes a long time. Mm-hmm. There doesn't seem to be any shortcuts. Contacts are an issue. The bulk fill eliminates the incremental curing.
That's right.
Are you pretty much only doing bulk fill on posterior?
Yes, I think
MOD?
For posterior composites, other than maybe a simple class 1, typically we use bulk fill almost all the way. Yeah, and of course, if it's a large restoration, I mean, the patients are given the options of inlays or onlays or even crowns if necessary. Yeah.
Would you mind going through that technique? Because I still talk to a lot of dentists who are not even aware of the bulk fill technique. They're not aware that there's an ultrasonic vibrator agitator with this technique.
Yeah.
So
I think in bulk fill technology, the whole idea is, if we can, just to go one increment, to save time. In terms of the other difficulties in posterior composite, things like bonding sensitivities, I mean, the newer generations of bonding agents have pretty much eliminated all that, as well as the newer matrix systems as well, the right wedging system. Pretty much you can get pretty nice tight contacts. So right now, I think the last part that slows things down is still the layering concept in posterior composites. So with the new bulk fill technologies, you basically have two different groups of bulk fill composites. There's one which is the flowable. So this is flowable bulk fill. So it gets great adaptation. But being flowable, once it's cured, it does have a bit of limitations in terms of the hardness. So the final layer, you need to just use a regular composite just on top. And on the other end of bulk fill, where those what they call high viscosity bulk fill, which is really nice and hard, good fracture toughness. But the problem is because it's high viscosity, it doesn't flow well, you can't wet the cavity well. So you still need to use a what they call a flowable composite as a thin liner before you put on the bulk fill. So in the end, it's still double, 2 increments at least. Yeah. So what happened was there's a company called Kerr, which came up with a sort of a new kind of composite where it's delivered in the capsule that's connected to a handpiece that's made by Cavo. So the high frequency vibration from the handpiece actually reduces the viscosity of this composite by about 70 to 80%. So when the sound or when the sonic device is on, the composite actually flows. And the moment you stop the device, the residual energy in the composite slowly moves away. It takes a few minutes for it to lose all its vibrational energy, and during that time, it's quite easy to sculpt the material, to carve in the anatomy, and once you are done, you just cure it.
And how does light curing go? Is it dual cure or light
Well,
cure?
most of the published evidence suggests that it can be cured up to a depth of 5, even 6 millimeters. Of course, the material is still quite new, 3 to 4 years on the market. Yes, but independent tests, and in fact, some of the tests were done by the ADA, the American Dental Association, and they find the depth of cure even up to 6.5, but the manufacturers recommend not going more than 5. And typically, I think for most posterior composites cavity preparations, 80% of them are about below 5 millimeters. So in almost all, 80% of cases, you can just go for a single increment.
Now, see, I would think since we were sitting in Asia, when you said the ADA, you'd be referring to the Australian Dental Association.
Okay, yeah. I think worldwide, not many associations have their own independent laboratory.
Oh, is that
Yeah,
right?
that's right. I think so. The ADA has its own independent laboratory that does the test, so it's we are told it's unbiased.
So it's 100% light cured. It's not dual cured.
No,
100% light cured.
yeah, that's right.
Light cured. And you've been using them for how long?
2 years?
2 years.
Yeah.
And what do you see after 2 years?
So we won't go back. Yeah,
You wouldn't go back.
yeah. I have about 12 associates in my practice. They all of them use.
Is it faster?
Yes, it's a lot faster. Yeah, for sure.
And you said it's by Kerr, and the device is by Cavo.
Cavo, that's right. Yeah.
But both of those companies are owned by Danaher, so it'd be really the same company, right?
Only not too long ago, I think. Yeah.
Yeah. Interesting. I've been to the Cavo factory in Germany. That was an impressive factory. So when you said you take away the sonic energy, how long do you have to carve the occlusion?
You have about at least 2 minutes.
2
Yeah.
minutes
Or more.
And I want you to talk about occlusion because you're a very great student of occlusion too. You studied with Clayton Chan out in Las Vegas. Occlusion really does seem to be one of the most.
It's a bit like a religion.
It is. I didn't want to say that. I didn't want to
Yeah.
offend you, but yeah, it's
Yeah.
religion. Everybody
So,
has a different belief.
I guess all of them kind of agree on the basic principles. I think the only slight disagreement is where to put the mandible. You know, everyone agrees that you need anterior guidance, you need canine guidance, you need balanced contacts, things like that. But I think the slight disagreement is where exactly do you put the mandible? Do you put it where the joints are in the anterior superior position, or do you put it in the position where the muscles are comfortable? You know, or I would say that's basically the main difference between most of the occlusal philosophies. Yeah.
I want to ask you one controversial. Some people say that TMJ,
Yeah.
TMD, TMJ, temporomandibular, that when a human around the world is stressed, they'll have 5 spasms: a brain spasm, headache, jaw spasm, TMJ, lower back spasm, irritable bowel, heart. Do you believe stress is a big factor of TMJ, TMD, pain disorders, or do you think it has to do more with mechanical forces and functions?
I think it's very difficult to pinpoint a single cause. It's almost always multifactorial. So I think stress can be useful to the body, you know, and stress, if it's too much stress, it can also be harmful to the body as well. But definitely, I would say stress would be a contributory factor in almost all diseases. Yeah.
Interesting. And I should have started also with Invisalign. I mean, my gosh, you were the first Invisalign dedicated clinic in Singapore, and now there's only 2, right?
Basically, we were sort of Singapore was chosen in a way like a test hub. So we actually had 2 Invisalign dedicated clinics starting about the same time. We sort of opened officially within about a week of each other, and we were the first 2 in Asia. And about a few months, slightly about a year later, they had 1 more in Bangkok, and I think Bangkok, Thailand. And in the UK now, I think there's also a Invisalign dedicated clinic, sort of recognized by Align. We have sort of permission from Align to call ourselves Invisalign dedicated center or clinic. Of course, there are lots of practices around the world that do limit themselves to Invisalign only or clear orthodontic aligners only. Yeah, so pretty much it was like a kind of like a test, you could say a test hub, because Align Technology wanted to see how it would work out. Yeah, so it's a center for a bit of research, and we have doctors from around Asia visiting our practices just to get an idea to see whether it's like a prototype to see how far Align can take this.
Now, ortho and endo, well, pretty much all of life is kind of the 80-20 rule. Well, 80-20 where, like, take endo. I mean, single-rooted teeth are just so much easier than a molar.
That's right.
A class 1 is so much easier than a class 2 or a class 3. Do you cherry-pick orthodontic cases and just do the easy gravy ones with Invisalign like class 1? Or do you use them for more complicated cases, class 2s, class 3s?
I think over the years, Invisalign has been evolving. So now it's already at the G6 or generation 6, which includes an extraction protocol. So when we first started back in 2004, yes, it was basically just mild crowding, class 1 malocclusions. And slowly as we get more experience, we're able to then start doing more and more complex cases. So right now, I would say probably about 80% of most malocclusions can be treated by Invisalign.
80% of
up to 80%. Yeah.
4 out of 5?
That's just an anecdotal kind of a rough estimate. I mean, I can't give you any
what
studies.
What cases would you not do?
Orthodontic surgery, for the moment, I will leave that to the specialists, although Invisalign can treat orthodontic surgical cases as well, and there's a lot of orthodontists who do that. But as a general practitioner, of course, we keep to the more simple to moderate cases as well. Yeah.
I've been very impressed. When I got out of school, orthodontic surgery, when you would go visit the patient in the hospital afterwards, I mean, their head was so swollen, you were scared.
Yeah.
In 87. And they have gotten that procedure so minimally more invasive over the last 30 years. I mean, it's really not that big a deal anymore.
That's right.
Do you agree?
Yeah.
Yeah. That might have been one of the most advanced procedures that I've seen in my lifetime. I mean, I'll still remember seeing one of my first patients that got referred to the oral surgeon to have done.
Yeah. Now with the mini plates, I think it has changed the surgery amazingly.
So you're talking to a lot of kids out there that have never done an Invisalign case. What are the advantages and disadvantages of Invisalign versus fixed brackets?
I think in the terms of aesthetic dentistry, I think we use a lot of Invisalign in patients who are looking for veneers or looking for a new smile. So many times they need some simple alignment. So the aligners are clear, so that the patient who's aesthetically conscious they don't have to go through what we call the railroad tracks. Yeah. And then secondly, of course, they're removable, so it's actually very comfortable for the customers, for our patients, and they can take it off to clean, to brush, to floss. Yeah. And pretty much in terms of treatment planning, I mean, as a dentist, you can actually have a visual treatment plan. You can actually show the patients the before and the after. So you have a rough idea how the tooth movements are going to be. On the software.
And is that free software from Invisalign?
Yeah, that's the software that's it's free. I mean, you need to be paid to get certified, but pretty much each time you have a case, you are charged a case fee, but the case fee comes with the software. I mean, the software is internet-based software. You just log on and all your cases are there on the cloud.
I've always thought that they should put an intro course or the Invisalign certification course on Dentaltown, just for marketing. I mean, there's 210,000 dentists on there. They should. I think they should put it their whole program or something just to intro it, because I think more dentists would be interested to go get certified if they knew more about it firsthand. But just not knowing anything about it and then going all the way to signing up to get certified is a bigger jump. I think it would disintermediate the sales process to say, well, let's just put it on your phone app so you can watch it there, and then they might learn enough about Invisalign to sit there and say, I think I am going to go get certified. Right.
Well, there's a new CEO, so you might want to give him a call.
What's his name? Or
at the moment, it just escapes me, but yeah.
Can you email me, Howard at dentaltown.com, and email and CC him and introduce us? Because my
Well, I'll get to see him in May. We have the Invisalign Asia Summit in May in Macau.
Oh,
Yeah.
Macau, that's the Las Vegas casino.
Yeah, that's right. That's right.
So have you've been to Vegas several times? Have you been to Macau
Yeah.
before?
Yeah, in fact, the last Asian Summit 4 years ago was in Macau as well.
So is it pretty comparable to Las Vegas?
Pretty much, just that everyone around you is Asian rather than Westerners in that sense. Yeah.
Yeah.
So the hotels are owned by the same companies that own the hotels in Vegas. Yeah.
Yeah.
So it's pretty much you do feel like you're in Vegas when walking through the casinos. Just that if you stop by the table, the stakes are a lot higher. Yeah.
There's
in
a lot more money.
Chinese, yeah,
Yeah, a lot
it's
more.
in the blood, gambling. We don't game, they gamble. Yeah.
Yeah. Yeah, I got really close to Macau, but I didn't on the trip, and couldn't swing by. One of the negatives that I hear dentists worry about with Invisalign is that if I glue on brackets, I control you're wearing them. I glued them onto your teeth. You can't take them off.
Yeah.
If I give you a removable retainer,
That's right.
So how often do you start someone with Invisalign? Well, tell me this: how long does the Invisalign case last, and how long would it have lasted if you would have gone railroad tracks so that you had control of the patient time wearing it? Does it take a lot longer because the patients don't comply as often, or is compliance really not an issue?
I think compliance definitely is an issue. As long as a removable appliance is definitely always an issue.
Whenever you're dealing with a human, it's an issue.
Yeah, that's right. So in Invisalign, in our practice, it's mainly adults-oriented orthodontics. So the interesting thing, or what's a bit different about Invisalign, is that you can actually sort of program the tooth movements. You can actually decide which teeth that you want to move. So sometimes when the occlusion is pretty good and settled, and the patients are just looking for some improvement and not for a full correction to a class 1, because some of them may be 40 and they are in class 2 all their lives, and all they want to is just to align the front 4 incisors and maybe just correct the lower imbrication. So using Invisalign, we can actually control the teeth movement and just give the patient what they want without making the malocclusion worse. So in that case, the treatment time is a lot shorter. Whereas if you were to put the full braces on, then obviously the time taken will be longer. So it varies from case to case, but generally we find our patients don't mind if the Invisalign case takes longer than braces, because what happens with Invisalign is obviously it's not very obvious, and no one really knows they're on Invisalign. And normally by about the 6th to 9th month period, the smile has improved pretty dramatically. So even if the treatment drags on another year or two, they're already so used to the aligners and they're invisible, they don't really complain. Yeah, but that said, I think most cases in terms of treatment time is comparable to fixed braces. Sometimes it's faster, sometimes it's slower. Yeah.
So is the common Asian orthodontic mouth bimaxillary protrusive, is it usually all non-extraction, or do you ever need...
Well, it depends a lot on our patient as well. How much their profile, how much the side profile bothers them. So of course in Asia, I mean, most of the movie stars, we're still very much influenced by what we see on the West. And we know that the Western profile is quite different from the Asian profile.
Explain that more in detail. How does the Asian profile look different than a Western
So typically, one parameter of aesthetic facial line is what we call the aesthetic line or the E line, where you draw a line from the nose to the chin in the lateral view. And typically, ideal look, the lip basically should be on the line. Yeah, but Asians, we have a shorter cranial base. Sometimes the nose is a bit underdeveloped or a bit short, and the chin can be smaller. So as a result, the E line is further back and the lips are beyond the E line, and that gives that protrusive look. So some of our patients are bothered by it. Then in that case, we may have to extract if we cannot create enough space through expansion. Some patients are very happy with the way they look, because with a prognathic look, you tend to look, especially for the ladies, they always look young. Because as you grow older, the soft tissue, you start to droop and you show less of your teeth. But if you have slightly bimax appearance, you always smile and you always have that young looking look. Which is why when sometimes Western tourists, they come to Asia, they find it a bit hard to tell the Asian ladies how old they are. Because even in their 50s and 60s, when they smile, because of the bimax appearance, they show a lot of teeth. So So some of our patients, they like the Bimax appearance. So for those cases, we can just align the teeth, straighten it without having to extract.
Every time I am completely off on someone's age by a decade or more, they're always Asian or African.
Yeah, exactly. Even Africans as well tend to be bimaxillary as well. So when they smile, you always see the full smile. You see some gums, even when they are past 40.
So you're saying these Western women who are getting all this Botox and dermafill, they're trying to look Asian. They're
Not
trying
really.
to get
I
their
think they're
lips
just trying to
past
look.
that line.
Just trying to compensate for maybe the loss of soft tissue volume as we age. Yeah.
Well, the one thing about beauty, it's interesting if you go back through history, it's the parameters are always changing. So what's beautiful today wasn't beautiful 100 years ago
That's
or
right.
1,000 years ago. I mean, look at all the Greek paintings, what they thought was beautiful and interesting. So what when you're worried about compliance, are there any things you've picked up? I mean, are girls more compliant than guys, or on guys or young guys less compliant than older guys? Is there anything you picked up? Any red flags?
Probably the group that is a slightly less compliant would be the teenage boys.
Yeah.
Yeah, we don't do that many teenagers, but I think that's beginning to pick up in fact in the US as well as in Asia. So we are seeing more teenagers asking for Invisalign, but we find that the boys are the one that they tend to be more active, and they tend to be a bit less compliant. Yeah,
They seem to be a lot less beauty driven.
that's right. Yeah, that's right.
I noticed with my four boys, they'd get a shirt they like and want to wear it 4 days in a row. And now he's flipping me off behind the camera. So now, do you do any fixed ortho, or is it all removable?
Right now, I think our practice is about 95% clear aligners. So if the patient needs a fixed case, we refer it to the orthodontist.
So now,
Necessary,
in the Invisalign dedicated practice, is that office only do Invisalign, or do you do?
We do
general
hygiene.
You do
and
hygiene.
We do some whitening as well. Yeah, teeth whitening and
Teeth
hygiene.
whitening.
Yeah, because we have our practices are just next door to each other. We have two practices. So the one next door is the one that does the general dentistry, the implants, the aesthetics, and the veneers. And then the next door is just the Invisalign dedicated practice. Yeah.
And does Asia dentists use hygienists to the same ratio?
Oh,
as
definitely. I think
the
no.
Americans?
The short answer would be no. I think most countries in Southeast Asia do not really have hygienists. Yeah. Most dentists in this part of the world do the hygiene themselves. Yeah.
And do you see the hygiene profession growing, or not really, or do you see the dentists just doing it?
I think it depends which country that you go to. So in some Southeast Asian countries, there are quite a lot of dentists. And then in some other countries, there's a real need for more dental personnel. Yeah. But specifically, I can comment in Singapore. I think definitely we definitely need more hygienists going forward. Yeah.
How many dental schools are
There's
in
only
Singapore?
one dental school in Singapore. Yeah.
And how many does it have a hygiene department?
No, hygiene department is under the polytechnic, whereas the dental school is under the university.
So Singapore is about what, 7 million people?
Yeah, about coming to 6 million.
6 million, and how many dental students does it graduate a year?
Per year, typically it's about close to 50, but
50?
we are in the process of building a new dental school. So once that completed, we should be able to bump up to about 80.
And how many hygienists do you graduate a year?
The exact numbers I'm not too sure because I'm not involved. I teach part-time in the university, but I'm not involved with the polytechnic. If I'm not wrong, about 30 hygienists a year.
30,
about there, yeah.
Yeah, and what we've seen in the United States is it's about 125,000 general dentists, 30,000 specialists, so talking 155,000. But you have to graduate almost 400,000 hygienists because they are in and out of the workforce with babies and things like that. But they try to aim for about 2 hygienists for every dentist. But interesting. I want to go back to that bulk fill just because I think that's a really hot thing. You talked about Sonic Fill by Kerr, which is owned by what did I just say?
Danaher? Oh.
Danaher.
Yeah.
But you said,
I think so. I'm not too sure.
Yeah. Kerr's owned by Danaher, which also owns Cable. But there's also the Dentsply which just merged with Dentsply Sirona. Dentsply has a Surefill.
Yes,
that-
I think they do have I think almost every major dental company now has some form of bulk fill composite. 3M has its own. Yeah,
Do
even
you want to
GC.
comment on any of the others? Do you like any others, or are you just really
As I
sold
mentioned
on the
earlier,
system?
some of them are just high viscosity and some are lower. So, I mean, each of course has its own advantages and disadvantages. But when we started with sonic fill, we found the unique properties of sonic fill, something that sort
So
of
you really like
worked
the
very well.
the sonic
Oh yeah,
edge
that's
there.
right, that's right.
That's the main takeaway there. I want to get to other issues. In America, we've heard that the Asian diet over the last decade or two has increased a lot of sugars and carbohydrates. Do you think, like your country, Singapore, you were born in Malaysia?
That's right.
Do you think a 6-year-old child in Malaysia or Singapore today has more cavities than they did, say, a generation ago?
Actually, at one point, Singapore had the lowest, decay rate in the world. Actually, yeah, that was because of active fluoridation in the
Fluoridated water.
Yeah, that's right. But again, with the change of diet, I think the sugar consumption has gone up. So decay rate has definitely gone up. With the fluoride therapy, we do find the incidence of what they call the blowout lesion has increased. But that's kind of anecdotal amongst my dental friends. They're seeing more kids with pretty pristine teeth, but sometimes you just find that little dot on the occlusal of the molar, and further exploration is sort of like a pretty big blowout lesion. And we suspect that although fluoride has its advantage in protecting the teeth, but it can also cause some of these blowout lesions if the dentist is not sort of vigilant in looking out for it. Yeah.
So all of Singapore is water fluoridation?
Yeah, that's right.
And explain the blowout lesion one more time.
Well, basically what happens is because of the fluoridation, the enamel is more resistant to tooth decay. But sometimes in the very deepest grooves, this area is still vulnerable. And when the caries start, it can't really spread laterally, it spread inwards. And once it's below, past the enamel into the dentine, it spreads sideways along the enamel dentinal junction. But because the enamel is still pretty hard, it's not easily detectable. Because previously, because of the lower fluoride, you could actually see the decay from the occlusal surface more easily. Now it's sort of like hidden until it's actually quite big.
And how does the Singapore people react to the government putting fluoride in the water? In the United States, there's about 19,000 towns, and on any given day, 25 or 30% of the towns have voted out of the water because they think it's bad for you.
Yeah.
So United States has averaged about 7 out of 10 cities have had it because there's no national policy on it. It's a city by city referendum.
That's right.
So do the people of Singapore, what percent of the people of Singapore say we trust the dentist, we trust the science, we like this, or they're upset that it's in their water and they want it out?
I think it's developed now, but during the developing times, I mean, the population, they're generally more preoccupied with other things. But of course, there are pockets of my patients that are against fluoride. But you can always buy what they call filtered water or distilled water, depending. So no one really forces you to drink the water if you don't want to. But pretty much, I think in Asia, the population tends to be quite compliant, with whatever the government is doing, unless, of course, there's really strong evidence. But I think the Ministry of Health in Singapore is very proactive about this. So even as dentists, we are quite aware of this fluoride issue for a while. And then they've been looking at the evidence as well. But so far, from what we see, the evidence of fluoridation seem to outweigh some of the disadvantages. I mean, there's talk of like increased hip fractures, cancer, and things like that. But I think it takes a while to really verify the evidence. So for patients who ask me, I'll say, topical fluoride works pretty well. So as long as you're using topical fluoride toothpaste, then if you feel that the fluoride in the water is harmful, just go for distilled water.
And what is the most popular toothpaste in Asia?
I think, again, it varies from country to country. I think in Singapore, it's probably a good fight between, probably Colgate would be probably number one. And Oral-B is also trying pretty hard.
Oral-B toothpaste?
Oral-B toothpaste. And recently, in the last few years, even Sensodyne has been taking up market share. Yeah.
Interesting. That is interesting. Some of these mouthwash, you're in the aesthetic dentistry area. There's a lot of over-the-counter aesthetic products, toothpastes that claim they whiten.
Yeah.
Now there's a lot of mouthwashes that claim they whiten. Do you recommend any of those to your patients? Do you buy into that, or do you?
I think the only mouthwash we tend to recommend would be maybe chlorhexidine in patients who are either post-surgery or kind of active periodontal disease. Patients on braces, we do recommend fluoride mouthwashes as well. But generally, we just tell our patients the most important is to brush and to floss well. If you brush and floss well, there's really no need for any mouthwash. But of course, if you belong to that minority that really have a very bad halitosis or bad breath issues, there's some mouthwash that we do recommend to them. Yeah.
I want to go back to something they used to teach when I was in dental school, and tell me if it's misinformation or information. They told us that I was formerly taught in school that Asians have more periodontal disease because they have a constrictive cervical neck. So it's a very constriction, and plaque and tartar precipitate, forming tartar more. And that Africans had the least amount of periodontal disease because they had the most bulbous cervical neck that didn't mechanically precipitate plaque and tartars, and Europeans were out in the middle. True, false?
I've not really heard of that.
You never heard of that?
Yeah.
Do you believe Asians have a more constrictive cervical neck around their teeth?
I think in Asians, the soft tissue is definitely thinner. Yeah,
you believe
soft tissue is definitely thinner.
Do you think there's more gum disease in Asia?
In day-to-day practice, it's hard for me to tell because it's like every patient is Asian, so you can't really tell the difference. I'm not aware of any research in that area, so I really can't comment on that. But what I do know is when it comes to implants, for Asian patients, typically once they lose the teeth, we don't have much bone left, for the implants, and grafting is usually difficult because the soft tissue tends to be a lot thinner.
I know you're headed for time. How much more time do I get him? I get 5 more minutes? My last subject, and this is a selfish question for me since I've always had a weight problem. You recently just were telling me you changed your diet 4 years ago.
Well, slightly more than 4 to 5 years ago. I think it started back in 2004. I was mentioning I went to LVI. Basically, the causes there really changed the way we look at malocclusions. And then we continued with Clayton, as you mentioned. And so that set me off a journey of why malocclusions happen. And if you dig up ancient skulls 10,000 years ago, everybody pretty much had straight teeth. And even in Asia, when you travel to, let's say, Nepal or areas where there's clean air, clean food, natural things, and everyone has a nice, broad smile. So genetically, we are meant to have a nice, beautiful smile. But we find that nowadays, malocclusion is more common. And many times it's due to allergies, rhinitis, runny nose, that causes our young kids to breathe through the mouth, and then the tongue position is altered, and you get a narrow arch and you get crooked teeth. And then going further back, what causes this rhinitis? It's actually allergies, and you can actually trace it a lot of times to diet. It could be processed food, and some people who are sensitive to wheat, could be GMO wheat, could be the gluten, we are not exactly sure. And also if you have a very high carbohydrate diet or high sugar diet, that causes inflammation as well. And that will again create more mucus, enlarged tonsils and things like that. So there's a lot of evidence showing that if we sort of move away from a modern day diet, more towards a natural diet or what we used to eat 10,000 years ago, where it was difficult to get simple carbohydrates. You couldn't get wheat that easily. You have to grind it manually and all that. So I think it's been going on I think started mainly in the States, in Australia, what they call a paleo-like diet, something that our ancestors ate. And there's quite a bit of evidence showing that that diet actually helps. Because by avoiding simple carbohydrates and sugar, we actually can control our insulin level. And by keeping our insulin level low, we signal to our body not to store fat. And by not storing fat, that we naturally lose weight. So by going on a low carbohydrate diet, that helps to actually lose weight quite easily. And by taking more healthy fats, you don't feel hungry most of the time. And after a while, as you get less dependent on carbohydrates, the enzymes and hormones in your body change, and you start to able to burn more fat. especially as long as your insulin level remains low, then your body after a while you adapt, and we call it fat adaptation, and you start to use the fat and sort of naturally lose weight. Yeah, it may not work for everyone, but I think we are all different. But generally, all of us have insulin, so as long as you don't trigger insulin spikes in the body, yes, it makes sense that you can actually lose weight by controlling your insulin level.
So, be more specific. What would you eat on average day? Do you eat breakfast, lunch, dinner?
What do you
tell?
Eggs in the morning. I fry eggs with butter from cows which feed on grass, not on corn, because the cows that feed on corn have too much omega-6, too much inflammation. And then for lunch, could be a salad, or it could be, if we go for Chinese food, we'll order maybe a soup with some vegetables and meat. Yeah, so dinner at home could be fried vegetables, a bit of meat. Yeah, sometimes a bit of carbohydrates, a bit of rice, but not too much. So when I was actively losing weight or losing fats, I avoided simple carbohydrates altogether. But once sort of reach your ideal kind of BMI, then you can start to increase a bit of carbohydrate consumption. Yeah. But the interesting thing about starting on this diet was we realized that our whole family was actually sensitive to wheat. By avoiding wheat, we could remove all the bloat. We used to feel bloated. We thought that maybe because we ate too much, but it's actually from the wheat. Yeah, we're not sure why. And if you eat pizza made from ancient grains, the reaction from the body is quite different than pizza made from mass-produced grains or wheat. Yeah.
My brother has celiac sprue, and my sister's one of her 3 children has celiac sprue.
Celiac disease?
Celiac disease.
Yeah.
I'm sorry. Yeah, they used to call it celiac sprue in Kansas. I don't know if that was a
Yeah. But I think the
Kansas term,
celiac part,
yeah,
there's a wide
celiac
range.
disease.
There's some of us which are subclinical. We don't really show the symptoms, but like for my example, my wife, she used to get ulcers in the mouth maybe every month
Canker sores?
for many years. Small aptus ulcers,
Yeah.
almost every month. And when we discovered that our son was actually sensitive to wheat, whole family sort of stopped taking wheat to support him. And then she realized that she stopped getting ulcers, for the whole year. And sometimes she would cheat and have a bowl of noodles, and next week the ulcers come back. Yeah.
Yeah, because everyone always thought those were autoimmune ulcers.
Yeah, that's right.
Abscess ulcers.
That's right. Yeah.
Well, seriously, it was a huge honor that you would meet with me today, and I was sitting in on your lecture. I wish you'd give that at a townie meeting some year. But you're just amazing. Any chance we could ever get an online CE course from you on Dental Town?
Definitely. You can keep the option open. Yeah.
I mean, that would just be, we would just love it. It'd be a huge honor. And thank you for all you've done for dentistry, and thank you for spending time.
Thank you. I remember joining Dental Town back in 2005. Yeah.
Man, it's been a long time, hasn't it?
Yeah.
Yeah,
that's right.
Back in the day. Well, hey, I don't want to be the guy who makes you miss your plane back from Indonesia to back home to Singapore. So thanks again for all that you do.
Pleasure.
Okay, bye-bye.